welcome to the next session, which is the Youth Mental Health session that's going to be led by Dr. Irfan Mian. My name is Miriam. I'm a fourth-year medical student at U Ottawa, and I'll be moderating this session. Just a couple of announcements before we get started. There will be some interactive polls in some of the sessions, so make sure you look out for those and participate. And there's also points for engaging in various aspects of this virtual conference for a chance to win prizes like complimentary registration to next year's conference. And there are some gift cards that you can also win as well. Points are awarded for actions such as answering poll questions during sessions, posting about the conference on Instagram, Facebook, and Twitter, or using our hashtag, which is hashtag MMHC2020. As well as completing some of the evaluation forms. There will be a question and answers period, except it will be at the end of the next session. So it won't be at the end of this one, that will be at 4:45. So if you have questions, make sure you put them in the chat, but they'll be answered at the end of the next session. And just a reminder that sessions for December 12th are non-accredited. Only the sessions tomorrow, so December 13th, are the accredited sessions. There are resources available as well on muslimmentalhealth.ca. Just to go over some of the goals for the session, they include reviewing common mental health conditions in youth, differentiating normal adolescent behavior from mental health challenges, as well as discussing common treatment modalities and approaches in youth. So before I hand this over, I'm just going to go over a short biography of Dr. Mian's. So throughout his career, Dr. Mian has been dedicated to the mental health care of children, youth, and their families. He's a psychiatrist at the Hospital for Sick Children and an assistant professor in the Department of Psychiatry at the University of Toronto, where he has committed to the academic mission in the areas of teaching and education. He serves as the undergraduate medical director in the Division of Child and Youth Mental Health in the Department of Psychiatry at the University of Toronto, and as the undergraduate medical education site director for the Department of Psychiatry at the Hospital for Sick Children. In addition to patient care, Dr. Mian has a passion for undergraduate and postgraduate medical education, and as well his creative professional activity endeavors focus on education and knowledge translation with physician groups, interdisciplinary education, and public and community education. So without further ado, I'd like to pass this on to Dr. Mian.
Hello and assalamu alaikum. Thank you for the introduction. It's hard to follow on the excellent last presentation, and some of my material is a bit repetitive, but focused on children and youth. Just going to, share the screen here. All right, can everybody see the slide set? So I was going to focus today on anxiety and depression, and Arfina and Sama, who have had the pleasure of working with at SickKids, are going to be talking about the family piece and parenting to follow this this part. So I don't have any conflicts of interest to declare. Wanted to make the similar disclaimer to other people that for any medical conditions, the advice of a healthcare professional specific to you should be obtained. And this presentation is not meant to replace the advice of a healthcare professional in any way. Sorry, just wanted to, we had just to see who was in the audience and maybe what you're hoping to learn from this session today. Though I'm not sure if this is programmed in as it is, okay. Okay, so a wide variety, and I was we're trying to make the two presentations useful for a variety of people, the health professionals and public audience members, so hopefully it will be. And the second poll question is, what are you hoping to learn from this session? All right, so people wanting to learn about all of the different goals. The first one a little bit less so, though we will be talking about common anxiety and mood presentations in kids. I also wanted to talk about an approach to psychiatry with kids and their families. I am focused, as I'm being repetitive, I know, on anxiety and depression because we had to focus down on something today, but as child psychiatrists, we certainly do work with the whole spectrum of presentations and disorders, including more common things like ADHD and disruptive behavior, as well as more really serious things like psychosis and bipolar disorder. So we see the whole spread of issues with children and especially teenagers. Sorry, I'm so bad with the Zoom. Here we go. The goals, which Mariam kindly had already reviewed. So reviewing some of the common disorders, differentiating normal kind of child and adolescent behaviors from mental health challenges, and discussing some common treatment approaches. Thought I'd start with the idea of assessment because it's something that is sometimes a bit of a mystery to families especially. But when we're seeing kids and teenagers who are referred usually from their family physicians or sometimes pediatricians, we do quite thorough and detailed interviews about presenting concerns, the kind of symptoms they're experiencing, but we also want their medical history and developmental history and pregnancy history and kind of family history. So it's often very detailed. Sometimes it seems intrusive, but the pieces of information can be quite important in formulating a diagnosis and treatment plan. When we see kids and teenagers, we tend to meet the family together, but we'll almost always see the kids alone as well, especially with teenagers. It might be the bulk of the interview on their own. A lot of families coming in have questions about confidentiality and who gets to see the information and who has access. And I know in the previous presentation, Dr. Majzoub talked a bit about confidentiality. So it's similar to with adults from the healthcare side. It's we would only share information within a circle of care. We also wouldn't share it if people especially didn't want us to, but the circle of care means kind of the other specialists or family doctors or in the hospital, the healthcare team that's involved with them. We wouldn't be sending any kind of information outside. We wouldn't send it to friends or other family or especially schools unless there was very specific consent from the youth and the family. Don't want to get too much into the legislation, but it's called PHIPA, Personal Health Information Protection Act. Kind of with the PHIPA, which is an Ontario-based legislation, if a youth is 16 and up, they're assumed to have the full capacity to be in control of their health record. But it doesn't mean that younger kids aren't. So there's actually no age to consent of release of your healthcare information. Sick kids' health records actually, I think, uses 12 or used to. So parents do often struggle with that, but we have to balance healthcare with what the legislation says. So again, I put a notation here about school, but we also like to gather a lot of information from schools, but of course we only do that when the families are open to it and willing. We use lots of screening tools. but some of the other things we do that psychiatrists do that maybe other mental health professionals might not do are assessing around medical conditions and medical history and how those or medications they're on for other things like asthma or arthritis or all kinds of medical disorders could interplay with emotions. And certainly a part of almost every assessment, not for the youngest kids, but certainly once you get into teens, is evaluating the risk of self-harm and suicide and aggression, and protective factors from suicide is the big thing. Sometimes it seems a bit out of place when we're asking, but it's sort of part and parcel of what we do, and it would be very rare for us not to ask an adolescent about self-harm and suicidal thoughts and behaviors. So anxiety disorders are the most common psychiatric disorders in children and youth. The prevalence rates are 10 to 20%. Some of the problems with statistic are numbers are very variable, and different studies will have widely varied numbers. And it's really important to distinguish between what's developmentally normative and what becomes a disorder, because anxiety is a part and parcel of life. Lots of kids, I say kids, but kids and youth will have lots of anxieties and worries. But it starts to become a disorder when, like they had mentioned in the previous talk, it really starts to be extremely distressing or starts to cause significant impairment or interference with your life. And with kids, it would mean they can't socialize, or they're not able to keep up with their schoolwork, or they can't take part in presentations. The more the distress or dysfunction related to the anxiety or worries, the more likely it is to be a disorder. But again, everything's a spectrum, so sometimes it is subjective. Because you can have you can be anywhere along the spectrum with any of these kinds of anxiety symptoms and disorders. So there is a bit of subjectivity to it, but the idea is to relieve distress and improve functioning. So we try and do that whether or not we call it a disorder. I won't spend too much time on it, but I did want to go through some of the anxiety disorders. And in general, the anxiety disorders are really based on the main or central worry or fear that's involved. So I have a bunch of lengthy slides, but just with the time we have, I'll try not to delay too much. Generalized anxiety disorder is probably the most common one, and it's kind of kids or youth or even adults who worry about anything and everything. Kids where parents might think of them as, one of the terms is worry warts. It's supposed to last for a certain amount of time, 6 months, to call it a disorder. Youth will often worry about the future, finances, health, their loved ones, school, world events, anything they see on the news, safety, car accidents, plane crashes, earthquakes. So the worries in generalized anxiety disorder should, again, cause a lot of distress, enough that they're seeking help or interfere with functioning. The kids and youth with this are often afraid of new things, need a lot of reassurance from their parents, can be quite irritable and restless when they're anxious, and often will have trouble sleeping. Going to move on to the next one, separation anxiety disorder. I won't talk too much about this. It's usually younger kids, and it's when the key area of separation is being away from their parents or perhaps grandparents or other caregivers that's out of keeping with their age. So, 3, 4, 5, we probably wouldn't be calling it this, but as they get older, we would. And the central worry is often that something bad can happen to them or to often their mom, sometimes their father, if they're away from them. They're the kind of kids who will check in with their parents over and over, will call them at work, will text them multiple times a day. And often it's also associated with refusal to go to school because they don't want to be away from mom or dad. Social anxiety disorder is one that is more common in youth and adolescents. And the key worry is about kind of being the center of attention, being judged by others, doing things that are embarrassing, and can also involve severe anxiety around presentations or performance. So for example, I get very anxious doing presentations, but I can force myself to do them. So I probably wouldn't quite meet the criteria for a social anxiety disorder. If I did, I would not be doing it. But there will again be a lot of distress or dysfunction related to it. Some other descriptions I put here with social anxiety disorder, if it's kind of with grown-ups because they're afraid of grown-ups judgment, that's quite different. It should be about their peers as well. It says must be capable of developing relationships. So that's kind of to rule out things that are maybe like autism spectrum disorders where the social skills deficits are more pronounced. And lots of kids are shy, but shy kids will usually warm up. They'll be comfortable around their group of people. In 15, 20 minutes at a birthday party or something, they'd be okay. Whereas the socially anxious kids won't, and they'll just want to leave or be back at home or want their parents with them. Selective mutism is an anxiety disorder where kids and teenagers will really only speak with close family members. It doesn't usually affect teenagers. Usually younger kids. Specific phobias, everybody's probably similar with the very specific fears around things like heights or blood or mice or insects, and they might have a panic attack related to it, or they'll need someone to come with them if they're around the stressor. Panic attacks are where you feel intensely anxious, have intense discomfort, and to meet the criteria, you need to have a certain number of physical symptoms like numbness or tingling, heart racing, breathing quickly. So panic attacks can happen with any of the anxiety disorders. And to have a panic disorder is having very specific criteria where the panic disorders themselves are the issue. Post-traumatic stress disorder is something else to keep in mind, especially working with people who've had traumatic experiences either in Canada or prior to coming to Canada, or have a traumatic immigration story. And the key areas of symptoms are re-experiencing the trauma would be one, avoidance of reminders and not showing much emotion would be the second, and symptoms of being quite anxious and hyperarousal, so easily startled, easily scared. It's not officially an anxiety disorder, but it belongs in some new category called trauma and stressor related disorders. I realize I'm taking a long time, so I won't talk too much about obsessive compulsive disorder. And I know Dr. Al-Majzoub, I hope I'm saying your name right, talked about it a bit already. But obsessions are the thoughts or images that are intrusive and prominent and distressing, and not just about real life worries, so not kind of just like generalized anxiety disorder. The most common themes are diseases or dirt or germs or order or aggression. I think they had talked about religious obsessions, and those are quite common, and some people call that type of OCD a scrupulosity. There are too many names for things. And compulsions are repeated behaviors or mental acts that are done often in response to obsessions, but sometimes on their own. And I think they had previously mentioned praying in response to some of the more religious themes, but other common ones are hand washing and cleaning and organizing. And again, it's a spectrum, but at some point if it starts to be too distressing or causes trouble with school or friendships or family life, it's probably reaching over into being a disorder. It also is officially, it's not an anxiety disorder anymore. It has its own class, obsessive compulsive and related disorders, but until a few years ago was part of the whole anxiety disorder spectrum. Just wanted to talk about risk factors. This is for anxiety disorders in general. One big one is a family history of related disorders. And heritability, it kind of refers to how much is related to genes, and it's quite high. So for most disorders, it's fairly high, but for anxiety disorders, it can vary anywhere from 30% to almost 70%. With OCD, it's probably 50%. Certainly childhood traumas, difficult life events and stressors. And I think there's going to be a great talk tomorrow on Islamophobia, and there have been some talks about racism already. Anxiety disorders tend to be more common in females than males and seem to be more common with low socioeconomic status individuals. So some things to keep in mind around risk. Um, so some of the impacts around anxiety disorders are that they can lead to other disorders. Even anxiety disorders themselves tend to occur in multiples. So if you have one anxiety disorder, 40% of kids with one anxiety disorder will have two or more. So it's common to have more than one. Often it's a precursor to depression. It can also lead to substance use, especially social anxiety disorder. Sometimes it's a precursor to eating disorders or self-harm behaviors. And certainly the things we see more the negative effects on school performance and interactions. And those are the big reasons we want to treat. Sorry, I'm just wanting to talk about treatment. And so there are three main areas of treatment. One is education about anxiety disorders, teaching kids and their families what the anxiety disorder is, how common it is, what might lead to it, and what the treatments are. Often will involve the school, but again, only with consent. There are a lot of different kinds of therapies. The mainstay is cognitive behavioral therapy. I'll talk a little bit more about that, and sometimes medications. The SSRIs are a class of medications that are often used for anxiety and depression. One that's often in the media or you might read about is fluoxetine or Prozac. And so with psychotherapy, there are a number of approaches. With kids and teens, we almost always want to involve the family in some capacity. A lot of the therapy with anxiety disorders is building a skill set and teaching kids and teens that they can challenge the anxiety, taking a step-by-step approach to conquering it. CBT has the most evidence and support, and it addresses the connections between thoughts and feelings and behaviors. A big part of CBT is actually challenging the anxious thoughts and looking for evidence that they're not true. And with anxiety disorders, it should be unrealistic worries. That would be the cornerstone. So, if you have a major medical disease and you're worried about the complications of it, you can't challenge those thoughts because they're actual things that are likely to happen, and you need to learn other strategies. And the acceptance came up a little bit. Acceptance and commitment therapy is a subtype of CBT that we probably don't have time to get into. Medications, again, the more severe the illness, the more likely medications are needed. There is a fair bit of evidence in using medications for the treatment of anxiety disorders. It's also important to treat any other disorders that might be accompanying the anxiety disorder. Medications are sometimes beneficial if there's only been a partial response to psychotherapy, and there's evidence that probably combination therapy is better for more severe disorders. And so just to summarize around anxiety disorders, they are the most common mental health disorders, at least in youth. They're characterized by worrying or fears that are quite impairing or cause a great deal of distress. Anxiety disorders can often co-occur, and one can often lead to another, and they do have effective treatments. So I'm going to move on, and sorry, I feel like I'm rushing a bit. I wanted to talk about depression. In psychiatry, we again have too many names for things. They're sometimes useful. The most common when we talk about clinical depression, we're usually talking about the first on this slide, major depressive disorder. Kind of a more chronic, lower grade depression would be dysthymia. But it's also important, and this is where kind of the general medical piece becomes quite important. Diseases, other kinds of diseases can cause depressive symptoms. So certainly hypothyroidism is a classic one where people can be tired and low energy and have low mood, and it's related to the thyroid being low. Concussions can have a variety of symptoms. B12 deficiency can mimic the symptoms. The SLE is lupus, which is an autoimmune disorder that can mimic a lot of psychiatric illnesses. monos, an infection that can mimic depression, and certainly substance-induced mood disorders. So kids, you rarely see it. Youth, you would start to sometimes see different either prescription medications or drugs of abuse that are causing depressive symptoms. And the bottom two, I'm not going to talk about. So some of the risk factors for depression. So they certainly overlap with anxiety disorders. And so probably all of those things are also relevant here. Again, family history is important. The heritability is probably around 50%. So a little bit more than it might be for things like schizophrenia. Prior depressive episodes, so having one depressive episode is probably the biggest risk for having another. History of anxiety, ADHD, learning disorders, but probably anxiety is the most prominent, and early losses. So things like death of a parent or severe things like that would increase your risk. Family dysfunction or conflict with the child and parents, peer problems, and academic difficulties, and kids and teens with chronic illnesses, as well as adults, are much more at risk for depression. And again, just racism and adverse experiences certainly heighten the risk of depression in youth who are already undergoing so many changes without having these added on stressors. Some of the common symptoms, so I didn't, they talked about it in the last talk as well, but the kind of the cognitive symptoms, or the depressed mood, or anhedonia is the losing interest in things. So teenagers won't want to go out with their friends, or won't want to spend family time, or won't take pleasure in things they used to. They'll have trouble with sleeping too much or too little, low energy, poor self-esteem, trouble with concentration in school, and of course the main one of the main concerns is the depression and the other symptoms leading to thoughts of death or suicide, and that, I think that was talked about a fair bit in the last session, so I won't go through it so much. The one difference from adult depression is kids and youth are allowed to have an irritable mood and not be clearly depressed and still have depression. Whereas in adults, they really have to have a depressed mood and or anhedonia. Again, this is a slide on comorbidity. So comorbidity is having more than one disorder. And in youth with depression, they often do have more than one disorder. So the depression may be on top of things we talked about already: anxiety disorders, learning disorders, ADHD, eating disorders, substance use. And so, you know, usually up to half of youth in studies would have a comorbid or another disorder as well. Comorbidity makes things more difficult because it's harder to treat. You need to treat both disorders, and there's always an interplay between them that needs to be taken into account. I wanted to highlight the impact of depression. Sorry, I just... So only half of teens with depression are diagnosed before adulthood. And so that would come from studies with adults where they are looking retrospectively. Depression is the leading cause of disability worldwide. And that's not just for youth, but for adults as well. And untreated depression can cause significant disability and impairment. And I kind of listed a whole number of areas, almost every area of a youth's life: school, relationships with peers and their family, pretty well all their daily activities, getting more involved in risky behaviors, and the risk of suicide, which is something we always like to assess for. A few statistics, just to highlight, I know my numbers are actually higher than in the last talk, so a much more pessimistic view of the prevalence of depression. But the main point is that it does happen in youth, not as much as in adults, probably half as much, but we also see it in children, but probably it's a very low rate, and it's usually in children who have a strong family history and often psychosocial stressors. So not so common in the, the under 12s, but it does happen. Relapse rates are fairly high. And the rates of suicide, unfortunately, are fairly high, especially without treatment. In kind of pre-teens, the suicide rates are extremely low. This is probably North America. So it's about 1 in 100,000, which is still quite high for little kids. And it's about 10 times that in youth. It's still lower than adults. But the kind of high school surveys looking at suicidal thoughts of any kind, so it could be passing thoughts, I wish I was dead, or it could be more active thoughts about actually having some type of plan, are quite common. About a quarter of girls at some point in a year in high school might have a thought like that, and with boys a little bit less. And again, as they reflected in the last session, risk of suicide requires an urgent or an emergent assessment. Just wanted to talk about the management of depression, and there are a couple of different areas. So there's the medications, and then there's psychosocial strategies. And so from a psychosocial point of view, wanting to talk with youth and their parents about depression, often we'll use a medical model where it is a treatable illness. There are studies that show effective treatments, and that we can help and they can get better. School interventions are important. So often during the midst of a depressive episode, youth will need more supports at school, or might need accommodations, have their schoolwork adjusted, have more time to get things in, have extra time on tests. So those can be quite helpful. Sorry. Sometimes kids do miss a whole term because of depression. Kids who end up being in hospital for depression sometimes will end up missing a semester, but usually we try to keep that from happening. There are different kinds of psychotherapies, which are similar to what was talked about in the last session. With kids, of course, we try and do the family piece, and add in family work and how family can be helpful. The cornerstone psychotherapy is, again, cognitive behavioral therapy, as it was for anxiety disorders. There's another one I put here. It's called interpersonal therapy for adolescents, which has a fair bit of evidence, but there are not that many practitioners in Toronto or anywhere, so it's hard to get. And lifestyle changes, and these are quite important. Sleep really has a big impact on mood. So trying to get kids to have regular sleep habits, to get at least, I try and get them to have 10 hours of sleep, but nobody does. I know there was the talk earlier today on addictions, and gaming and internet use really get in the way of sleep. Nutrition can be quite important, and exercise. There's evidence and studies to show that aerobic exercise can help with depression. I always think we probably didn't need studies, but they do exist. Sorry, the next slide is on medication treatments, though I have a few things on this slide. Similar to anxiety disorders, the more severe the depression, the more we look at using medication in combination with therapy. And again, it's this class of medications called SSRIs. So Prozac or fluoxetine was the first. We'll often use other antidepressants if 2 or 3 trials of the SSRIs don't work. There's much less evidence with kids and youth with other antidepressants. There are a whole bunch of other kinds of medications we may use, but that would usually be with psychiatry involvement. Typically tends to be the SSRIs of that whole class of medications. There are studies showing that combination treatment is more effective, probably more effective in preventing relapse and recurrence. Some standard combination would be fluoxetine and cognitive behavioral therapy. And just highlighting the importance of referring to specialty care and looking for psychiatry, some psychology input for especially comorbid substance use disorders. And I think you had the talk on addictions earlier today. If there's a poor response to 1 or 2 SSRI trials, I would usually suggest family doctors or pediatricians refer kids to psychiatry, or even earlier. With suicidal concerns, again, depending on the degree of thoughts, but if there's any kind of plan or intent, having a more urgent assessment done. and certainly referring to specialty care, or sometimes the emergency room is the best place if there are concerns about mania or psychosis. Mania is kind of the opposite mood state of depression. So where people will have a persistent elevation of their mood. They'll be either extremely high and irritable or euphoric, don't need to sleep, talking a mile a minute. We don't have time today for that, but the other thing to keep in mind with youth with depression is it can be the first manifestation of bipolar disorder, and a high percentage of kids with a clinical depression will convert to mania or bipolar disorder. So something else to keep in mind. Really severe depression on its own can be accompanied by psychosis. And often it might be voices or hallucinations that are in keeping with themes around depression or critical of the youth. And again, those are require more urgent assessments. So either if there is an urgent care clinic, or if that's not accessible, the emergency room makes a lot of sense, and it is probably a necessity at those points. And sorry, this is my last slide. So a summary, depression is common in adolescents, certainly not as common as in adults, but as they get older, start to approach adult levels. Depression needs to be differentiated from sadness, or there's another disorder called an adjustment disorder where you can have depressive symptoms in response to something, but clinical depression tends to be persistent. It tends to be lasting, and it tends to have some of the physical symptoms with effects on sleeping and eating and energy and concentration, as well as the loss of interest, the sadness, guilt, and the thoughts about death. Again, untreated depression can lead to disability in numerous ways, substance use, and an increased risk of suicide. And there are very effective treatments for depression. And so that makes it even more important to have it assessed and treated. And family is very important in the assessment and the whole process of management and treatment of depression. So I think that was my last slide. And I don't know if we want to finish early or...
Thank you so much, Dr. Mian, for this informative session. We still have a few minutes and a couple of questions.
Yeah, I could answer those. Sorry.
Yeah.
I'm talking over you. I didn't mean to.
It was really great. Thank you so much. There's one question asking about whether there is data on the percentage of Muslim children impacted by anxiety or other sort of psychiatric disorders.
I don't know of any particular data. I do know, rates of depression seem to be quite similar in different parts of the world. And certainly here in Toronto, it's a very multicultural population. And I do see a wide variety of kids, including a lot of kids who are Muslim with anxiety and depression. But I don't know the studies that might show that. I'll ask Irfan and Sama after. I know there was another question there. Oh, it just disappeared. Medications. So medications, the antidepressants aren't really weight dependent. We do start much lower with kids and teens. And sometimes though, kids and teens need higher doses than adults because their livers, which metabolize the medication, work much better. But we'll almost always start, or I always start at the lowest available dose, or even split them. That being said, I'm thinking of younger kids, but if you get into the 16, 17, 18-year-olds who are as big as adults, I'll probably start at like half the adult dose and then work their way up. Oh, there are lots of questions. How to prevent adolescents from suicide ideas when they have depression and their family factor, like a broken home, is the cause of the depression. We do a lot of family work. I'm used to more managing the suicide risk with kids in the hospital. I don't do it as much with outpatients, but in the hospital, we do tons of family work, safety planning, coping strategies, getting the kids and teens to teens and parents to work together to come up with plans of how they can communicate much better, how the parents can help the youth to remain safe, and what kinds of interventions need to happen. So that's quite an involved process, and it does require a lot of family involvement. So it's really important. The advantage of working with teens is you often have families or parents who you can bring into the picture and work on things with the teens. Sometimes with adults, you don't get to have that as much, and you don't have the parents looking out for the kids or supporting them in the same kind of way. How can we support friends with depression? Older teens, when we do a lot of coping strategies and safety planning with teenagers, we do have them reach out to friends and use friends as support. But when it comes to risk of suicide and safety, it's more of a life and death situation. And we really want the teens to have adults who are also involved in this protective circle around them. And we even want friends to reach out to their parents if there's a concern about suicide and that kind of safety. So for suicide, we really depend on the adults being available and involving them. We do have cases where the family aren't really fulfilling that role. Then we need to look into other strategies, whether it's a group home or an alternate family member, but those are more the extreme cases rather than the bulk of cases. The next question, has there been an increase or an upward trend in anxiety and depression in the past few years with the prevalence of social media? I mean, anecdotally, at hospitals across North America, we do see a lot. We think there's an increase. It's not established scientifically. Well, it might be, but I'm not sure. But we certainly see an increase in high risk behaviors and more severe depression and higher anxiety. And nobody is quite sure why. I mean, is it more of a social phenomenon rather than being a purely medical psychiatric phenomenon? There's so much interplay. We don't know the answer, but there certainly are patterns that are shifting. I don't know the empirical evidence or the research in the area to give that clear research-based answer. Sorry, there are a whole bunch of questions. One is, maybe I'll answer the marijuana one. Is there a correlation between schizophrenia and marijuana? I was told if the parent has a mental illness and the offspring smoke marijuana, they have a high risk of developing a mental illness. Is this true? The parent has an and the offspring somewhere. So marijuana is quite well established as being an independent risk factor for the development of schizophrenia. And it probably is dose dependent. So the more cannabis you use, the higher the risk. It's there's also a building literature on it being an independent risk factor for the development of bipolar disorder, not as clear cut as for schizophrenia. Then around anxiety disorders and panic disorder and OCD, the literature is not as clear. Some of the kids I see who have a family history of bipolar disorder or schizophrenia, I do my utmost to counsel them around the heightened risk they have, and that even if their friends can use cannabis, they really shouldn't. But there are plenty of studies showing the kind of dose-dependent effect, or the more cannabis you use, the greater the risk of schizophrenia. And I know it's 4:44. Should we probably stop, or there's so many important questions? I guess it'll be good to have Irfan and Sama's input as well when we answer them together later on.
Exactly. Yeah, we can continue answering those later on. I just wanted to thank you again for this amazing talking session on youth mental health. Dr. Mian, thank you.
You're welcome.
I also wanted to thank all the attendees and everyone who participated in the polls and asking questions. It's all much appreciated.